Now we'll go ahead with the master class. Okay. Whatever we have seen up till now, same we will discuss. Yes, who wants to take the turn? Who wants to take the turn?
I'll read some.
Five slides. Okay, five questions. We have almost 50 questions, so everyone can have their turn.
Yes.
Yes. Yeah.
A 30-year-old woman presents to emergency department with lower abdominal pain at 7 weeks. She's conceived via ovulation induction and intrauterine insemination. Transvaginal ultrasound shows an intrauterine G-sac with fetal heartbeat. The right adnexa shows a complex mass, and there's a moderate amount of free fluid in pelvis. Her serum beta HCG is 12,500. Most likely diagnosis. It is a heterotopic pregnancy. Option A, corpus luteal cyst. B, tubal ectopic pregnancy. C, heterotopic pregnancy. D, threatened miscarriage. E, ovarian torsion. It is C, heterotopic pregnancy.
Correct. Very good. See, when you are reading the SB, now you are reading, so you are reading completely. But in the final, when you are appearing for this examination, you should read very fast and directly go for the option. So when you are solving or practicing, keep the time. Okay.
Yes,
Remember,
sir.
for SB it is less than 1 minute. We have to come to less than 1 minute. There will be few, hardly 20 seconds. You save that particular time and give that time to EMQs. Okay. And
Yes, sir.
50 SBS, 55 minutes. This is what is our target. Okay. Maximum 60 minutes, not more than that. Okay. Everything is
Yes.
in our initial session. Next. So this is a heterotopic pregnancy. Heterotopic pregnancy is the coexistence of intrauterine and ectopic pregnancy. Risk is increased in assisted reproduction, particularly ovulation induction or IVF. Presence of intrauterine pregnancy does not exclude ectopic. So adnexal mass with intrauterine pregnancy plus free fluid, suspect heterotopic pregnancy. And in heterotopic, what we have seen that intrauterine pregnancy and continuation is going to be very, very important. Not only that, medical management methotrexate will not be helpful. It is possible only when the patient is not interested in continuation of the pregnancy. These are the things which we have already seen. Next question, Dr. Sinchana.
A 28-year-old woman is diagnosed with heterotopic pregnancy at 6 weeks gestation after IVF. A viable intrauterine pregnancy is confirmed. The ectopic component is tubal and unruptured. She is hemodynamically stable. What is the most appropriate next step in management? A. Systemic methotrexate. B. Expectant management. C. Laparoscopic salpingectomy. D. Laparotomy. E. Local injection of potassium chloride into the ectopic sac under ultrasound guidance. It is actually salpingectomy, sir, because she's having a viable intrauterine pregnancy.
Yeah, that is going to
And
be a more suitable option.
that laparoscopic
Laparoscopic
salpingectomy.
salpingectomy. Okay, methotrexate is contraindicated, that we have seen. Okay, laparoscopic surgery is the treatment of choice for tubal ectopic in heterotopic pregnancy to preserve the intrauterine pregnancy. Okay, local injection is used for non-tubal, that is cervical, cornal, etc. Expectant management is unsafe. Next,
A
Sinchana.
33 a 33-year-old woman presents at 7 weeks of gestation with lower abdominal pain and light vaginal bleeding. She is hemodynamically stable. Transvaginal ultrasound reveals an empty uterine cavity, but a G-sac is seen in the upper and lateral part of the uterus, surrounded by a thin rim of myometrium less than 5 mm in all planes. A echogenic line extending from endometrial cavity to the G-sac is noted, which is interstitial line sign. What is the
Without,
most?
yeah, without looking at the option, just can you tell the diagnosis?
It is an interstitial ectopic pregnancy.
Yeah, yeah. Okay, appropriate now. And what is going to be the management? They have asked about the management.
What is the most appropriate management? A. Systemic methotrexate. B. Expectant management. C. Manual vacuum aspiration. D. Cervical circlage. E. Laparoscopic salpingectomy. It is A. Systemic methotrexate.
Yes, yes. We have seen that which method and which type of ectopic. Here it is going to be the systemic methotrexate. Okay, systemic methotrexate is often appropriate in early unruptured cases in a stable patients. Expectant management is unsafe. Okay, MVA is not appropriate. Salpingectomy would not address the interstitial pregnancy which lies within the uterine musculature. Okay, So that is what is the explanation.
Yes,
Now
sir.
EMQ. Yeah.
Match the ultrasound findings with the most likely type of ectopic
Okay.
pregnancies.
I will show you these options. We'll go for the question.
Yes, sir.
Solve all four now. Solve all four one by one.
Okay,
One,
sir.
then I'll show you the option.
A 30-year-old woman presents with vaginal bleeding at 7 weeks. TVS shows empty uterus and a G-sac is seen embedded in lower anterior uterine segment at the site of previous cesarean scar. This indicates cesarean scar pregnancy.
E. Okay.
E.
Option is E. Next.
27-year-old woman conceived through IVF. She presents with pain and spotting. TVS shows intrauterine gestation and a right adnexal G-sac with a fetal pole and cardiac activity. The diagnosis is tubal ectopic pregnancy.
A. Okay.
No.
Okay.
Next.
A 20. Sorry, sir, it is heterotopic pregnancy. Heterotopic pregnancy.
Intrauterine gestation with right.
And
So
Yes.
right
yeah,
adnexal.
yeah.
Heterotopic.
Here, sorry, heterotopic. Correct.
D.
Correct. Yeah. Next.
26-year-old woman presents with spotting and pain. TVS shows an empty uterine cavity, but G-sac is located at the upper lateral aspect of the uterus with less than 5 mm myometrium surrounding it and a visible interstitial line sign. Diagnosis is interstitial ectopic pregnancy. B.
Correct. Mm.
34-year-old woman presents with painless heavy vaginal bleeding. TVS shows a G-sac located in the cervical canal with closed internal os and a absent sliding sign. Diagnosis is cervical ectopic pregnancy.
Yeah. So cesarean scar
EDB.
pregnancy, heterotopic pregnancy, interstitial ectopic,
Just
and cervical.
cervical.
Uh, uh, Anthony, you want to go ahead with the next few questions?
Okay, sir.
Yeah. EMQ. Okay. So these are the
Match
options.
the most.
Yeah, we'll go for the questions. I'll show you the options again. Okay.
Question 8. 25-year-old woman with an unruptured tubal ectopic pregnancy. Mass 25 millimeter. No fetal heartbeat. Beta ECG 1,200 international unit per liter. Asymptomatic and stable.
So it is unruptured tubal ectopic. Size is 25 millimeter. Beta ECG is this. She's asymptomatic. So match the appropriate first line option. What will you give?
Expectant.
No, no.
Expectant management.
Methotrexate.
No, Dr. Singh,
Methotrexate.
let him answer. Yes, Dr. Anthony, your turn. What is your answer?
Expectant management.
You want to go ahead with expectant management? What is the beta SCG for the expectant management?
Less than 1,000.
One less than 1.5.
No, there you consider. Okay, less than 1,000 you offer. Okay, up to 1,000 you can consider. Okay, but we'll see the discussion answer. Okay, go ahead with the next one.
A 32-year-old woman presents at 9 weeks with a ruptured interstitial pregnancy and hemodynamic instability.
So it is a ruptured interstitial pregnancy. Okay.
Should be laparoscopic sapingectomy. D.
Okay. Let's see. Next.
10. A 28-year-old woman has a cervical ectopic pregnancy with heavy vaginal bleeding. She is stable, but bleeding continues after MVA.
So it is a cervical ectopic and heavy vaginal bleeding. She's stable, but bleeding continues after MVA. What is the management?
I don't know. I'm not
Okay.
sure.
Okay. Next.
A 26-year-old woman with a small, non-viable tubal ectopic beta ECG of 300 IU per liter and falling levels over 2 days. Expectant management. A.
Very clear. Very clear. Okay. Here, no doubt, it is an expectant management. So let's see about the answer. First is a systemic methotrexate because the beta ECG was 1200. Okay. And the patient should be pain free and rest of the criteria should be there. Second, here it is a laparotomy with corneal resection. Okay. That was a case of this hemodynamic instability, interstitial pregnancy rupture. Okay. Then suction curettage with balloon tamponade. Okay. Woman with sorry, what was this? A 28-year-old woman has cervical ectopic with heavy vaginal bleeding. She is stable and bleeding continues after. So it is suction curettage with balloon tamponade. Okay. Then last one was ectopic management, expectant management. Yes, you want to continue, Dr. Anthony? You want to
No,
continue?
sir. No,
Huh?
sir.
Oh, but
No, sir.
okay. No, it's okay. Sansi, anyone else you want to
Yes,
continue?
sir.
Uh,
Match the risk factor.
yeah,
Should I?
okay. Yeah.
Okay. A
Question number 12.
30-year-old, yes, sir. A 30-year-old woman presents with a heterotopic pregnancy. She conceived with ovulation induction.
It is a
So,
heterotopic pregnancy.
pregnancy, IVF.
Risk factor. They are asking about the risk
Match
factor.
the risk factor with most likely ectopic pregnancy type. Prior tubal surgery in vitro fertilization, previous C-section, use of. So can I see the question once again, please?
Yes, yes.
A
That is the
30-year-old
way.
woman, a
Yeah,
30-year-old woman presents with a heterotopic pregnancy. She is conceived with ovulation induction. Okay. The option assisted ovulation, sir. E
yeah,
option.
yeah. Next.
A woman with previous pelvic inflammatory disease presents with a right side adnexal mass and no intrauterine gestation.
Very
The
clear
options
here.
are history of PID, sir. F option.
Yeah. Next.
A woman with 3 previous lower segment cesarean section presents with gestation implanted at scar site. Sir, option please.
Yeah.
C option, sir. Previous cesarean section.
These are simple ones. Actually, they are not so simple in final examination. I'm just giving you
Yes, sir.
simple to begin with.
Yes. A 35-year-old woman conceived via IVF and is diagnosed with interstitial ectopic pregnancy.
Here also,
B option, yes, IVF.
yeah. Yeah. So here it is assisted ovulation, then history of PID, previous cesarean section, in vitro fertilization. Very simple. Next, you want to go ahead, Sansi?
Yes, sir.
Yeah.
A woman with a tubal ectopic pregnancy treated with methotrexate shows a rising beta HCG on day 7.
So she is a tubal ectopic
Ectopic
pregnancy. She is
pregnancy,
treated with methotrexate and shows a rising beta
rising beta
HCG on
HCG.
day. So you have done it on day 4, then repeated on
Yes,
day 7,
day 7.
then day 4 and day 7. After repeating, there is a rise in.
Match the indication for surgical management with the clinical description. Match the indication for surgical management. Okay. Failed medical management, ruptured ectopic pregnancy, heterotopic pregnancy with viable intrauterine gestation, significant hemoperitoneum. Contraindication to methotrexate, desire for definitive treatment, rapidly rising beta HCG despite expectant management. Can I see the question once again, sir?
Yeah, yeah.
A woman with tubal ectopic pregnancy treated with methotrexate shows a rising beta HCG on day 7. Okay, it is increasing. Match the indication for surgical management. The clinical. Acha. Sir, we have to find the option in which we have to do the surgical management according to the question.
Yeah, yeah. According to the question.
Failed medical management, sir. Option A.
Yeah. But otherwise, when you have this, Dr. Sinchina, what will be the next step here?
We
Tubal
have to
Repeat
do
ectopic.
TVS.
USG, sir.
Repeat
Yeah.
USG and
TVS.
rule out
Yes,
fetal
yes,
cardiac activity and ruptured ectopic.
Ectopic
yes.
pregnancy.
Okay, and you have to see whether the patient is still in the range of medical management or not. You got it?
Mm.
Yes,
Then
sir.
only you will offer the repeat dose. Okay. If there is a cardiac activity, then straight away she goes out of the medical management. Okay, that is why
Ye-
the role of TVS is there. Yes,
Yes.
Nancy. Next question.
A woman presents with shoulder tip pain and ultrasound confirms free fluid and adnexal mass. She is tachycardic. So in this, contraindication to methotrexate. So
Why contraindication to methotrexate? What is the
significant
clinical?
a woman is
See, shoulder
presenting
tip
with
pain is there.
hemoperitoneum.
So
Hemoperitoneum. Yes, sir. Significant
Ru-
hemoperitoneum.
yes,
Ruptured.
ruptured ectopic
Third
pregnancy.
ectopic pregnancy.
Yeah,
Yes.
here again
Yes,
it's
yes.
confusing. Ruptured ectopic
Yes,
and significant
significant
hemoperitoneum.
hemoperitoneum.
Let's see what exactly the answer is, and then
Yes, sir.
we'll. Mhm.
A woman with heterotopic pregnancy and viable intrauterine fetus is stable with tubal ectopic seen. Okay. Option, sir.
Woman with heterotopic pregnancy and viable intrauterine
And
pregnancy.
intrauterine stable with
Hmm.
as it failed, a C option, so heterotopic pregnancy with viable intrauterine gestation.
Okay.
A woman with an unruptured ectopic requests a permanent solution and no future fertility. Desire for definitive treatment.
Correct. That is the desire for definitive. So failed medical management. Okay. Here ruptured ectopic pregnancy because it was having shoulder tip pain and all those things. Okay. Actually, the hemoperitoneumy is also one of this particular thing. Let's have, see what exactly to be selected. Then heterotopic pregnancy with viable intrauterine gestation and desire for definitive. Now, this was a present woman presents with shoulder tip pain and ultrasound confirms the free fluid and adnexal mass and she is tachycardic. So why not significant hemoperitoneum? Why ruptured ectopic? Actually, question itself is very short. There should be some
Is
additional. Yeah, yeah, yes, yes, Anthony. So question itself is very, short. It's not a very frame question. Yes, who wants to go ahead with the further questions? Dr. Indrani, Dr. Who else is there? Anyone wants to go ahead with the questions?
Sir, I can continue.
Yeah, yeah, continue, Doctor.
A 30-year-old woman with a tubal ectopic pregnancy undergoes laparoscopic salpingotomy. She is concerned about her future fertility and risk of complication. She has no known subfertility factors and the contralateral tube is healthy. Which of the following statement is most accurate regarding her future pregnancy outcomes and post-operative follow-up? Her chance of future intrauterine pregnancy is lower than if she had a salpingectomy. The risk of persistent trophoblast after salpingotomy is less than 1%. NICE guideline does not recommend follow-up beta HCG after salpingotomy if the ectopic was completely removed. Repeat ectopic pregnancy occurs more frequently after salpingotomy than salpingectomy. Women with subfertility factors have equal intrauterine pregnancy rates after either surgery. So BNC is not the answer, definitely. Which of the following
Okay.
statement is most accurate? BNC is not the answer, definitely, sir. Her
Yeah.
chance of future intrauterine pregnancy is lower than if she had a salpingectomy. Repeated ectopic pregnancy occurs more frequently after salpingotomy than salpingectomy. Women with subfertility factors have equal. The option A or E? I'm just confused in that.
Option D.
Yes,
D.
option D is the most
Doesn't.
correct. Okay, D is the
Okay.
most correct option. You see, why not E? Women with subfertility factors have equal intrauterine pregnancy rates after this surgery, whatever the surgery you do. No, see, they have a subfertility factors. So subfertility factors, salpingostomy is better than the salpingectomy. Okay, you got it. That is why this is not correct
Yes, ma'am.
answer. Okay, and her chance of future intrauterine pregnancy is lower than if she had salpingectomy. Here, actually, she has got a this. What is the
Healthy
control?
contralateral tube.
So this has,
Healthy.
so D is the only option correct.
Hmm.
See, such kind of questions will be there. So unless you have read the guideline properly, sometimes it is a bit difficult to judge only on the answers. Okay. So this explanation we have seen persistent trophoblast occurs 7% in salpingostomy, less than 1% in salpingectomy. Okay. So next question will be that only, I guess. Yes, continue, Dr. Sansi.
28-year-old woman undergoes laparoscopic salpingotomy for a tubal ectopic pregnancy. Histology confirms product of conception. She is asymptomatic on post-operative day 5. You are reviewing her for follow-up. Which of the following statement about persistent trophoblast following surgical management is most accurate? Persistent trophoblast is more common after salpingectomy than salpingotomy. Wrong. The incidence of persistent trophoblast after salpingotomy ranges from 1 to 3%. Okay. Nice recommends no follow-up beta HCG after salpingotomy. Histology confirms ectopic. Wrong. Persistent trophoblast occurs in approximately 7% of cases after salpingotomy. This is right. Persistent trophoblast does not occur if the ectopic was unruptured and completely removed. No, wrong. The B, I guess so, D option.
D
Yeah,
option.
D. Correct. Correct. Correct answer is D. Persistent trophoblast loss occurs in approximately 7% cases after the salpingotomy. Okay. So Dr. Sinchna continue now. Couple of questions. We'll come back to Dr. Sansi again.
A 27-year-old woman presents with mild lower abdominal pain and a positive pregnancy test. Transvaginal ultrasound reveals an empty uterus and a left agnusal mass measuring 25 with no fetal cardiac activity. Her serum beta HCG is 1300 units per liter. She is hemodynamically stable, has no significant medical history, and is willing to attend for follow up. Which of the following features would make her most suitable for medical management with methotrexate? Option A, serum beta HCG level of 6800. B, positive fetal cardiac activity in the mass. C, willingness and ability to attend follow up visits. D, as uncertain location of pregnancy. E, known hypersensitivity to methotrexate. It is C, willingness and ability to attend follow up visits.
Yeah. So it is very important the patient should be able to follow up. Okay. So willingness and ability to attend follow-up visits. Okay. That is one of the important thing. Next.
A 29-year-old woman is being counseled after treatment for her first tubal ectopic pregnancy. She asked about her chances of having another ectopic pregnancy in the future and whether the type of treatment, medical, surgical, or expectant, affects this risk. Which of the following statement is most accurate regarding the risk of recurrent ectopic pregnancy? Salpingectomy is associated with lowest risk of recurrence. Methotrexate treatment increases the chance of recurrence. Expected management has the highest recurrence rate. Recurrence rate is approximately 18.5% regardless of treatment type. Recurrence only occurs in women with bilateral tubal damage. It is D. Recurrence rate is 18.5% regardless of treatment.
Correct. Correct. So the recurrence rate is approximately 18.5% regardless of the treatment type. Okay. Long-term follow-up studies have shown no statistically significant difference in the risk of recurrent ectopic between medical, surgical, expectant management. The overall recurrence rate is 18.5%. Option A to C are incorrect because no mode of management significantly alters recurrence risk. And E is incorrect because recurrence can occur even in women with previously normal contralateral tube. Yes, continue, doctor.
A 24-year-old woman presents with vaginal bleeding at 5 plus 3 weeks gestation, confirmed by last menstrual period. She has no abdominal pain and no risk factors for ectopic pregnancy. On transvaginal ultrasound, the findings are inconclusive and the pregnancy of unknown location is documented. Which of the following is most appropriate next step in the management? Immediate serum beta HCG and repeat scan in 48 hours. Diagnostic curettage. Administer methotrexate empirically. Advise expectant management and repeat urine pregnancy test in 7 to 10 days. Laparoscopy to exclude ectopic pregnancy. Option A, serum beta HCG level and repeat scan in 48 hours.
See, there is a early pregnancy 5.3 weeks by LMP. There is no pain and no risk factors for ectopic. Okay, so early pregnancy with bleeding findings are inconclusive.
We
So
can go
one
for.
option is immediate serum beta HCG and repeat scan in 48 hours. Why to repeat scan in 48 hours?
Okay,
Why
sir.
to repeat in 48 hours?
Because she has no risk factor, we can also go for expectant management and repeat our urine pregnancy test in 7
Because
to
in
10 days.
48 hours, unless the beta HCG level is more than 1500, we will not be able to see the cardiac activity also. I think D should be the most appropriate option. Yeah, advise
Yes,
expectant management and repeat pregnancy test in 7 to 8 days. If a woman less than 6 weeks of gestation, bleeding without pain and no risk factors, expectant management is safe and appropriate. The woman should be advised to return if pain develops or bleeding worsens. A change urine pregnancy test after 7 to 10 days is used to confirm resolution. Beta HCG scan in 48 hours is appropriate if ectopic is suspected or the risk factor is exist. Okay.
Okay,
B,
sir.
C, and E are invasive, inappropriate at this stage in otherwise low risk asymptomatic vein. Okay, so
Yes, sir.
very careful. These questions, confuse a lot.
Yes, sir.
shall
Next,
I?
A 20, a
yes,
26-year-old.
anyone has got a question?
Shall I? Shall I
Yeah, yeah.
attempt?
Yes. Continue, continue. Doctor, who
Neeraja, Neeraja, Neeraja.
continue, doctor. No problem. Yeah.
26-year-old woman presents with the vaginal spotting at 6 weeks, 3 days by dates. A transvaginal ultrasound shows a single intrauterine GSAC with CRL of 6.2 mm, no visible heartbeat. She is clinically stable and findings are discussed with her. What is the most appropriate next step in management? Diagnose miscarriage after and offer surgical evacuation. Diagnose miscarriage and offer medical management and repeat scan within 48 hours. Repeat scan after at least 7 days. Refer her second opinion and immediate uterine evacuation. Option D is correct. Repeat scan after at least 7 days. TVS.
Absolutely correct. Absolutely. Doctor, can you please elaborate the explanation on the CRL,
Yes.
on the mean
Yes,
gestational
yes.
fact?
If it
Because
is
we want
less than
to,
CR,
yeah, we want to fix this particular thing here and here. So even if 10 questions are asked, you don't have to read back, go back and read the guideline. Let us clear everything here and here. Yes, doctor, go ahead with the explanation.
if it is less than 7 mm, we should repeat the scan TBS after 1 week, sir. The
Correct.
more than 7 mm, we expect the cardiac activity.
More than or equal to, remember, more than or equal to. Why
Yes, or
equal to?
equal to.
Because these equal values are more confusing. When you see that
Yes,
exact
yes,
same borderline value, you get confused what to do. Okay. Yeah.
yes.
So yeah, next, so what do you do in this case?
Repeat
Seek,
scan after 7,
seek
at least.
second opinion and or repeat scan after 7 days. You got it?
Yes,
Seek second
yes,
opinion and or repeat scan after 7 days. Okay. Next. Uh,
yes.
if it is a
GSAC,
mean
it is
gestational,
more than 25.
if it is a mean gestational sac diameter which is
More
measured,
than 25,
25.
25
Okay.
mm.
Yeah, same management is there. This we have
Yes.
discussed just now. Okay, go ahead with the next question, doctor.
Okay. 28-year-old woman presents at 7 plus 2 weeks by last menstrual period with mild spotting and but no pain. A trans-abdominal ultrasound is performed. Findings show a single intrauterine gestational sac with a mean sac diameter of 18 mm, but no visible fetal pole. She is clinically stable. What is the most appropriate next step in management? By doing our trans-abdominal scan, we should repeat after 14 days. And second
Absolutely.
means gestational second, diameter is less than 18 mm. We are supposed to repeat the scan after 14 days, trans-abdominal scan.
Yeah. So if it is a
Next step,
transabdominal, then it is a 14 days. If it is a TVS,
14
7
days,
days.
7
TVS,
days,
7 days. Transabdominal, 14 days. Okay. And
14
CIL,
days,
7 millimeter for TVS and MSD, 25. Okay. So these
25
are the
mm.
cutoffs. Correct. Okay. Repeat scan after at least 14 days. Okay. Yes. Next, doctor, continue. Till 30, you
Yeah,
continue. Someone else will take over.
okay, okay. 26-year-old woman presents at the early pregnancy unit with the positive pregnancy test and mild spotting. Initial beta HCG is to 820 and the repeat test 48 hours later shows raise to 1450, 1450 IU per liter. Transvaginal ultrasound at that time is inconclusive. What is the most appropriate next step? We have to calculate what percentage is increased. Okay. 1450 minus 820 is 30. 630 divided by
Mhm.
initial 820. So the rise is more than
Mhm.
diagnosed by next. Okay, she's stable, mild spotting, and start methotrexate for suspected ectopic pregnancy. Diagnose viable uterine trait in pregnancy and start antenatal. No, perform uterine. Only thing B is the answer.
You want to say start method exact or perform urgent suction criteria? B or D?
Sorry. Time is inconclusive.
C, it is.
Method,
C.
C shouldn't be
that's a
repeated scan.
urgent.
I think C.
Okay.
Repeat TBS in 7 to 14
Sca-
days or earlier if the beta ECG is more than 1500. Here you don't see the cardiac activity, but the beta ECG is
Yes,
increasing 1450. So generally we repeat the TBS once the value crosses more than 1500. So that
yes,
particular
yes.
concern they want you to know whether you know this particular thing and whether TVS is to be repeated after 7 days or not. So these are the things here they are expecting. So and increase
1500.
more than 63% over 48 hours suggest likely to be developing an intrauterine pregnancy. Okay, so these are the concepts you just apply what exactly, and then you see which is the best choice. Okay,
Okay. Okay.
yeah,
A
continue.
32-year-old woman with pregnancy of unknown location has the serum beta HCG 1200 IU per liter that decreases to 520 IU per liter after 48 hours. She is clinically well and has no pain. What is the most appropriate next step? After 48 hours, day 4 and day 7. The most appropriate next step. Advise UPT after 14 days. Start methotrexate due to falling SCC. Perform repeat SCC. Immediate ultrasound scan. Schedule elective evacuation of this falling is good. More than 15%. Advise UPT after 14 days. Sir.
Correct. Correct. So here that particular
Yes.
chart which is there, and remember after abortion
Yes.
it is 3 weeks. Okay, but here it is after 2 weeks. Okay, here we are doing about this what you can say
Fall.
PUL. Yeah. Okay. So advice urine pregnancy test after 14 days. A decrease more than 50% SCG over 48 hours suggests pregnancy is not viable and likely to be resolving. No intervention is needed unless symptoms change. Okay, advice you put in 14 days. If negative, no further action is required. If positive, review within 24 hours. Okay, methotrexate urgent scan, surgical evacuation is unnecessary in this case. Yes, I think there are 2 or 3. So you can take these questions, doctor. Read the stem first. This first most important is the stem. Okay, you understand the
Next
stem.
step.
Huh,
Most
huh.
appropriate next step.
Yeah.
in the management
Yeah. We'll go for the question, then I'll show you the
options. A 25-year-old woman presents with vaginal bleeding at 8 weeks. Vaginal bleeding. And she passes products of conception at home and repeat scan confirms an empty uterus with no retained product. She is asymptomatic and hemodynamically stable. Shall I have the options, sir?
yeah, yeah.
It is a
You want
complete
list it?
abortion. Complete abortion. Offer home UPT after 3 weeks.
Okay. Next question.
30-year-old woman diagnosed with a complete miscarriage at 9 weeks. She is RH negative and no other medical history. She has no other medical history. Complete miscarriage in less than 10 weeks.
Hmm.
Immediate surgical. Refer to emergency scan. Complete miscarriage. Weekly sir, shall I have question once again?
30-year-old woman.
Diagnosed with complete miscarriage at 9 weeks. She is RH negative. No other medical history. Miscarriage, after miscarriage, you can repeat the UPT after 3 weeks, sir.
Here, actually, it is going to be the same answer, but they are confusing here with RH negative.
Yes,
So
yes,
I
yes.
don't know whether what exactly the answer they have given, but because it is 9 weeks and it is a complete abortion, she should not require anti-D. Okay,
No,
go.
no anti-D. Yeah,
I don't know what.
27-year-old,
Yeah,
we'll
yeah.
see, sir. 27-year-old woman is managed expectantly for an early pregnancy loss. At 10 days, she reports increased bleeding with offensive discharge and fever. It is a infection, sir, post-abortion infection. Start empirical antibiotic first. Then you
Yes.
can,
Yeah. First is an
yeah,
antibiotic, then it's a surgical.
antibiotic.
Okay, then the
Yes,
surgical man. But first is a antibiotic. Let us see.
antibiotic.
So offer home pregnancy test after 3 weeks. Here they have given this, but actually, if it is a complete abortion and less than 10 weeks, unless it is a surgical abortion, then
Yes.
anti-D is not required. Okay, so I don't think this is a right. Okay, then answer C is a start empirical antibiotics. That is correct. So
For
this I.
medical abortion, no anti-D, no, sir. For
Yes,
medical, less than
medical
10
abortion
weeks.
less than 10 weeks not required. But if it is less than 10 weeks and if it is a surgical abortion, they mention consider anti-D. Okay.
Okay.
Next, doctor, who wants to go ahead with this? Sinchana, you want to read now?
Yes, sir.
Yeah.
A 29-year-old woman presents to early pregnancy assessment unit with lower abdominal pain and mild vaginal bleeding at 6 weeks of gestation. Transvaginal ultrasound reveals no intrauterine pregnancy and a provisional diagnosis of ectopic pregnancy is considered. Which of the following most accurately reflects the incidence of ectopic pregnancy in women attending early pregnancy unit? Option A 0.1%, option B 0.5%, option C 1%, D 2 to 3%, E 11%. It's option D 2 to 3%.
Because we are asking in the
Early
early
pregnancy
pregnancy
unit
unit. Okay. So early pregnancy unit 2 to 3%, general population 1.1%.
1.1%.
Next.
Which of the following best describes the incidence of ectopic pregnancy in general population? It is option A 0.1%. 1.1%. Option C 1.1%.
Yes, yes,
11
1.1.
per
Yeah.
10,000.
Okay, 11 per 1000. Okay. Next.
A 30-year-old woman presents with lower abdominal pain and positive pregnancy test. Transvaginal ultrasound is performed to evaluate for possible ectopic pregnancy. Which of the following is most common ultrasound finding in women with an ectopic pregnancy? A. Extrauterine G-sac containing yolk sac and or embryonic pole. B. Free fluid in pouch of Douglas. C. Empty intrauterine G-sac. D. Empty extrauterine G-sac. E. Inhomogeneous or non-cystic adnexal mass. It is E. Inhomogeneous or non-cystic adnexal mass.
How many percentages, doctor? How many
40 to 60%.
50 to 60%.
60%.
50 to 60 is the answer. C. Okay, inhomogeneous or non-cystic mass, most common. Okay, in 50 to 60% of cases.
50
Empty
60%.
GSAC is seen in 20 to 40%. It is 50 to 60, 20 to 40, and live or without cardiac activity, but EOSAC and G6, that is the
15 to
least, that
20.
is 15 to 20%. Okay.
In women diagnosed with ectopic pregnancy, what percentage typically demonstrate an extrauterine G-sac containing yolk sac and or embryonic pole on transvaginal ultrasound? It is C 15 to 20%.
Just now we have seen the same answer. Okay, so 15 to 20%. Same explanation is there. Okay, but this is not the common one feature. Okay, less common. Go ahead with this one.
A 27-year-old woman presents with mild pelvic pain and a positive pregnancy test. A transvaginal ultrasound shows a fluid collection within the uterine cavity, but no definite intrauterine G-sac is identified. You want to distinguish between true G-sac and a pseudosac. Which of the following ultrasound findings is most consistent with a true intrauterine pregnancy? A. Central fluid collection with no surrounding echogenic rim. B. Fluid collection without associated decidual thickening. C. Single echogenic rim surrounding a fluid collection. D. Fluid collection surrounded by two concentric echogenic rings. E. Thin endometrial lining with central stripe. So it is D. Collection surrounded by two concentric echogenic rings, which is a double decidual
Yeah,
sign.
DDS, what we call it is a double decidual sign. Okay, so fluid collection surrounded by two concentric echogenic rings, especially a double decidual sign, refers to the two concentric echogenic rings surround around in intrauterine fluid collection and is highly suggestive of true intrauterine pregnancy. A pseudosac is seen up to 20% of ectopic pregnancies may appear as a central fluid collection in the uterus, but lacks the defining features of a true G-sac, such as the intradecidual or double decidual sign. Recognizing these sonographic differences is crucial in the early diagnosis of ectopic pregnancy versus viable intrauterine pregnancy. So they are very fond of asking these ultrasound related questions. Okay, go ahead
Yes.
with this next one.
A 32-year-old woman presents with painless vaginal bleeding at 7 weeks gestation. She is hemodynamically stable. A transvaginal ultrasound shows an empty uterine cavity and a G sac located in the cervical canal below the level of internal os. There is peritrophoblastic flow around the sac on Doppler. Which of the following ultrasound finding is most characteristic of cervical pregnancy? A. Gestational sac located at the fundus of the uterus. B. Gestational sac with double decidual sign in mid uterus. C. Gestational sac located below the internal os in cervical canal. D. Inhomogeneous adnexal mass with free fluid in pelvis. E. Then endometrial lining with central fluid collection. It is C. Gestational sac located below the internal os in the cervical canal.
It's very clear. For cervical pregnancy, it has to be below the level of the internal os.
Inter
G-sac
os.
has to be, that is the location. Okay, and another is the absence of sliding sac.
Absent sliding skin.
Okay,
Increased
peritroplastic,
vasculature.
these particular features. Go ahead with the next question.
A 30-year-old woman with positive pregnancy test presents with mild pelvic pain. Transvaginal ultrasound shows an empty uterine cavity with G-sac located high and lateral in uterine cornua, surrounded by less than 5 mm of myometrium in all planes. A thin echogenic line extending from endometrial cavity to sac is also seen. Which of the following is most likely diagnosis based on these findings? It is interstitial pregnancy. D.
Very clear. Yeah, yeah. It is always surrounded by less than 5 mm myometrium, remember. Okay, and there is an interstitial lines, and
Interstitial
3D
lines.
ultrasound and MRI can help to differentiate it from angular pregnancy. Okay, so this also you have to remember. The next step will be 3D ultrasound, and if facilities are available, MRI you have to do. Okay, now we have finished with the ectopic. Now we have abortion nice guideline. Sansi, start few questions. Dr. Sansi.
Yes, sir. According to the NICE guideline on abortion care, what is the recommended time frame for providing an abortion after a woman makes request? Within 72 hours of the request, within 1 week of the assessment, within 2 weeks of the request, within 2 weeks of the assessment, within 72 hours of the request. Option A, sir.
Anyone else?
Within
Option
1
B.
week of assessment. C.
And Dr. Anthony, what you want to say? Your choice.
Within 1 week of request. B.
Time frame for abortion. Assessment should be within 1 week, and abortion should be within 1 week of assessment. That is what the guidelines is. So
Within
within
1 week of
week of
assessment.
assessment. Okay. So the abortion should be within 1 week of request. She should be assessed, and it should be provided within 1 week of assessment. The service should be provided. Okay. Next, Dr. Sansi, continue.
According to the NICE guideline, in which of the following scenarios is anti-D prophylaxis not required? RH negative woman undergoing surgical abortion at 7+0 weeks, RH negative woman undergoing medical abortion at 9+6 weeks, RH negative woman undergoing surgical abortion at 9+6 weeks, RH negative woman undergoing medical abortion at 12+0 weeks, RH positive woman undergoing medical abortion at 8+0 weeks. So option B, RH negative woman undergoing medical abortion at 9+6 weeks.
Yeah, correct. Okay, medical abortion does not require. Below 10 weeks, it does not require. And it is not required for medical abortion up to and including 10 weeks of gestation in RH negative women. Okay. Yeah. Next, continue.
According to NICE guideline, what is the recommendation regarding the use of antibiotic prophylaxis for medical abortion? Should be given to all women undergoing medical abortion to prevent infection? Is required only if gestation is about 12 weeks? Should be given to women with history of PID? Is not routinely needed for medical abortion? Must be administered before administering mifepristone. So option D, not
Yeah,
routinely needed for medical abortion.
correct, correct. Sansi will continue with the EMQs.
Yes, sir.
Go ahead with these 4 EMQs.
Yes, sir. A
They are
27 year
simple,
old
basically. Yeah,
a 27-year-old woman undergoing medical abortion at 8+4 weeks. She has no past medical history and no risk factor for pelvic infection. No
antibiotic.
antibiotics required.
No antibiotics required. Okay, next.
A 22-year-old woman is undergoing surgical abortion at 9+6 weeks of gestation. She has history of PID. Tox. Doxycycline 100 mg BD for 3 days.
Correct.
31-year-old woman is undergoing medical abortion at 11+3 weeks of gestation. You decide to offer antibiotic prophylaxis as per clinical judgment.
She is undergoing medical abortion and she is
Abortion
11.3 weeks of
3
gestation.
weeks. Doxycycline, sir.
So option?
Doxycycline.
Yes, but which B, C?
Okay. 100 once daily for. C option. 200 mg orally once daily for 1 day. No, B option. Doxycycline 100 mg twice daily for 3 days.
Okay, next.
A 29-year-old undergoing surgical abortions requests information about antibiotic prophylaxis to decide to prescribe standard recommended 3-day regimen. B option.
B.
So all 3 are B options only. Okay.
Yes.
So first, no antibiotics is required up to 10 weeks of gestation. Then next is 100 BD for 3 days, 100 BD for 3 days, and 100 BD. Okay. So beyond 10 weeks, it will be required. Same dose will be required. Okay. Who, Dr. Anthony, you want to continue? Few questions?
I'll
Yeah,
give it a try.
yeah. Good. Go ahead.
All right, so according to NICE guidelines, what is the recommended management for medical abortion at 10 weeks of gestation? A. Mifepristone and misoprostol should both be taken at home. Misoprostol must be administered in a clinic or hospital. Home expulsion can be offered. Misoprostol must be administered at home under remote supervision. Home expulsion is not recommended beyond 9 weeks, 9 plus 6 weeks. Women must remain in hospital until complete expulsion occurs. Option D or B.
Option
Sinchana, what is your
Option
choice?
B.
B.
Yeah.
B
So
option.
B option. Misoprostol must be administered in the clinic or hospital, but home expulsion can be permitted. Okay. So at 10 weeks of gestation, NICE supports the offering home expulsion after misoprostol use. However, misoprostol should be taken in a clinical setting, hospital or clinic, not at home. This balances safety and access, especially as gestational age advances. Okay. So these minor points, they just want you want to check. Okay. Yes, continue, Dr. Anthony.
According to standard regimen, what is the appropriate combination of mifepristone and misoprostol for medical abortion up to 49 days of amenorrhea? Mifepristone 200 mg orally, followed by 400 microgram misoprostol orally. Mifepristone 600 mg orally, followed by 400 microgram misoprostol orally, or 1 mg gemiprost vaginally. Mifepristone 600 mg orally, followed by 1 mg gemiprost vaginally. Mifepristone 200 mg orally, followed by 800 microgram misoprostol vaginally. Mifepristone 600 mg orally for cervical priming before surgical abortion. According to the standard regimen, what is the most appropriate combination of mifepristone and misoprostol? Mifepristone. Mifepristone 200 mg, followed by misoprostol 800 microgram.
They are asking 49 days. 49 days early gestation dose of mife is going to be high. So you will always have the mife option of, we only have two options, 200 or 600 mife. Okay, these are the only two options which we use. So the mife 600 is going to be
B.
choice.
B.
And iso dose will be low at 49 weeks of gestation. Okay, so option B. Okay.
600 followed by 400 or 1
Okay.
gram bonus.
Yeah. Yes, continue, Doctor. Next.
What 47? What is the appropriate dose of mifepristone for cervical priming before first trimester surgical abortion? 200 mg orally. A.
Yeah. So for priming, it is only 200. Mife we use only 200. Okay. And when we use mife, it has to be 24 hours prior minimum. Okay. Next.
Which of the following is an appropriate regimen for medical abortion at 50 to 63 days of amenorrhea? 50 to 63 days. I don't have an idea. It's confusing.
Confusing, no? Same thing happens. But just
50,
remember
50
that
to 60, those will reduce.
this will reduce, that will increase. Mife will reduce, miso will increase. So just select appropriately.
Okay. Should be D. 400 milligram mifepristone orally, followed by 1 milligram gemiprost vaginally. Option D, sir.
B or D?
A.
See, 400 microgram miso is only up to 49. Okay. So
800.
in mife we have two doses, 200 and 600. Okay. For between 50 to 63, I think both doses are can be used. So 600 along with 800 might be the most suitable option, or this is, I think B should be the most suitable, or C. Yeah, 600 with 1 milligram of gemiprost vaginally. Yes, the chart is there. They have given 1 milligram of gemiprost also. Yes, with 1 milligram of gemiprost, they have given 200 MIFE also and 600 meso also. Okay, so this is the correct option. Yes, next.
Which combination is appropriate for medical abortion up to 63 days using a lower mifepristone dose?
Yeah. Low mifepristone dose.
100 by 800.
200 milligram mifepristone orally followed by
This, I think B should be
800.
the, yeah, because they are asking about
Yes.
63 up to 49,
Okay.
400, that we know. Okay, and then this with 1 milligram of gemiprost, there are two doses, 200 and 400. Here they have given mife 400 and 600. That is why they are not correct. So if gemiprost is to be used, mife will be 200 or mife will be 600, and then they will be combined with 1 milligram of gemiprost. That is why these two are not correct. Okay, then this is also not correct because the dose is 400 here. So the only option here is a B. Okay, you got it.
All right, sir.
Yeah.
Which combination,
Next, this one is the next one. Yeah.
according to current guidelines, what is the recommended standard regimen for medical abortion between 10 weeks and 23 weeks and 6 days of gestation?
Yes, yes.
10 weeks and 23 weeks of gestation. A. Mifepristone 600 milligram orally followed by 400 microgram misoprostol orally every 4 hours. Mifepristone 200 milligram orally followed by 24 hours. No. C. Mifepristone 200 milligram orally followed by 36 to 48 hours later by 800 microgram misoprostol vaginally. Mifepristone 200 milligram orally followed immediately by 400 microgram misoprostol vaginally. 10 to 23 weeks is 3 hourly. The option should
Option C.
Yes, C is correct.
yes, option
C.
C.
Yeah, yeah. No doubt. This we have to remember. Okay, because this is going to be the commonly used, no, gestation where mife meso we are going. So 200 followed by after 36 to 4800 hours, 800 followed by 400 3 hours. Okay. So C, this is the dose. Okay. Someone else now. Okay, because let everyone have some confusion about the numbers. Who wants to? Dr. Sansi wants to try, or
Yes, sir.
yeah, yeah, few. Yes, yes.
A 200 milligram oral dose of mifepristone is administered as the first step in medical abortion. According to current guidelines, which misoprostol regimen is appropriate for the following gestational age group?
This
Match
is
each
EM.
gestational age group with the correct misoprostol dose and frequency.
Okay, this is the EMQ. These are the questions. So what they are saying, mifepristone 200 is given in the first step. Okay, the next subsequent step, what should be the protocol between 24 to 25, 25 to 28, and beyond 28. This also I have covered.
Yes,
Okay,
24
so
to
20,
25.
400
24 to
every 3
24.
hours.
400 every 3 hours.
okay, next.
25 to
25 to
28, 200. And beyond
200.
2800.
Yeah, but the duration initially it was 3 hourly. Here,
6 hourly.
6 hour. No,
no,
2
6
hour.
hourly
No,
will come along with 100.
20.
Hmm.
4
4.
hourly.
4 hourly.
Yes,
4 hourly. 3,
yes.
4, 6 years.
You got
Hmm.
it now. Now let's
Yes, sir.
come to answer. Okay, so the first was up to what? 24 to 25.
24 to 25. 400 misoprostol every 3 hours. C option.
C
C.
option.
Then
Hmm.
200.
200
200 every 4 hours.
4 hourly.
Then
And then 100
100
every
every
6
6
hours.
hours.
okay. So is it correct now? You getting now? You are able to
Yes,
recollect
sir.
this?
Yes,
Okay.
sir.
That is why not only reading, you have to practice. Yes. Go ahead with next question.
According to current guidelines, which of the following regimens is recommended for cervical priming prior to surgical abortion at less than equals to 13.6 of gestation? 800 microgram misoprostol vaginally 6 hours before the procedure, 400 microgram misoprostol sublingually 1 hour before the procedure, or vaginally 3 hours before, 200 microgram misoprostol orally 2 hours before the procedure, 600 microgram misoprostol sublingually immediately before the procedure, 400 microgram misoprostol orally 3 hours before the procedure. Sir, option B.
Option
400
E.
400 meso sublingually 1 hour
sublingually 1
before
hour
or
before the
vaginal. Correct. So option B, 400 microgram meso sublingually 1 hour before the procedure or vaginal 3 hours before. Yes, this is EMQ. Okay. What is the theme? It is an extended matching question. Cervical priming options prior to the surgical abortion by gestational age. Yes, Dr. Sansi, continue this.
cervical priming options prior to surgical abortion by gestational age. Okay. Lead in for each gestational age below, select the most appropriate cervical priming options prior to surgical abortion. Each option may be used once, more than once, or not at all.
Okay.
Miss, yes, sir.
Mhm.
A woman is undergoing surgical abortion at 14 plus 4 weeks of gestation.
14.4 weeks of
4,
gestation. What will be the
14.4.
priming? Cervical priming.
Cervical priming. Os, no,
Yes,
sir,
anyone
I'm
else?
confused.
C.
Yeah, yeah. Yes.
Option C.
Yeah.
Hospital
Between 14
visits
to
or
16 weeks, all three. OD, MF, MI. Okay. From
Yes.
16 weeks, MIFE cannot be used. So you have OD and MI. Okay. And after 19 weeks, you have only OD. Okay. If at all MIFE is to be used, it has to be used 24 hours prior to the OD. Okay.
Mm.
So the next is a
A woman scheduled for surgical abortion at 17.2. So it's
okay.
after
So that
16
is 16 weeks onwards.
weeks,
Okay.
16 weeks
So
onward.
what will
Yes.
be the option now? Here,
OD and MID. D option.
yeah. Okay.
Mm.
The next,
Woman presents for surgical abortion at 20.1. OD.
only
D
OD.
or only OD or MIFI.
yeah. See, you
Mifepristone
consider
rescue.
osmotic dilators or misoprostol, all three routes, or Mife. Okay, day before. Then only the osmotic dilators or misoprostol D. And here osmotic dilators and consider adding 200 milligrams of Mife the day before inserting the dilators. Okay, so this is what is of between 14 to 16, 16 to 19, 19 to 13 weeks. Here only OD is there, or consider adding Mife the day before insertion of the this particular thing. Okay, so I think that finishes the today's master class also. I hope all of you are getting this, or you feel that these questions and master class is important for you.
Yes, sir. It is very
Yes,
good.
Yes,
sir.
sir. Yes, sir.
Definitely.
Because